I'm a general radiologist who does a lot of breast imaging, probably half of my time spent in doing breast imaging. We have pretty large volume. So compared to some groups, I mean, it might be, the kind of the workload that maybe 2/3 of a day spent on breast imaging. And let's just go over that. The reason we adopted the Sofia breast ultrasound, I'll tell you about a sentinel case that happened. And I think everybody in the audience who does breast imaging probably already has an experience like this, but it was a 40-something-year-old woman with extremely dense breasts, came in for a screening mammogram, everything looked fine, negged it out, went to see her OB/GYN a couple of months later, had a palpable lump, came back for diagnostic testing. We ended up seeing a large mass on ultrasound. I think we even repeated the mammogram, still couldn't see anything, even retrospectively knowing where it was, biopsied it, was invasive cancer. And so this was like 2013, 14, something like that, and the OB/GYN came to us and actually asked us to come speak at their monthly departmental conference and asked what options there were, how does this get missed, and they were hearing in their national meetings about the need for supplemental testing. Also at the same time in New York State, just like in a lot of other states, there was the breast density notification law in 2013 that said we were required to tell the patients that they have dense breast tissue and that they should talk to their doctor about supplemental testing. And so that's when we forayed into doing screening breast ultrasounds sort of as more routine. We were doing initially handheld ultrasounds in patients with extremely dense breasts. And at the same time, this technology, the Sofia, came out, and we also looked at other vendors that offered automated breast ultrasound. Because when we started doing a lot of handheld screening ultrasounds, we started getting a lot of pushback from the techs. It's time consuming, it's physically tough on their body, and there was they're like, you want us to do, scan both breasts in their entirety, and starting to see a lot of patients doing this. And so we looked at the different vendors, and we ended up going with the Sofia system. And we'll talk about that a little bit, but kind of a little background on screening breast ultrasound. And one of the things I'll say that this is not an academic talk. I'm not anywhere on the level of Dr. Brenner. I'm just a radiologist who has done a lot of these, and I'm a believer in the technology. But if you talk about screening breast ultrasounds, most of you are probably familiar with the Akron 666 trial, and what they showed, about 4 more cancers per 1,000 patients that were screened. And one of the things that, the caveat to that though, is that that study was done on patients with increased risk for cancer, and also those patients were scanned with they were scanned by physicians, specially trained in doing this. So that's comparing handheld ultrasound to the screening breast ultrasound. And this basically just this says that the ultrasound could potentially outperform tomosynthesis. I will tell you that I think that they're supplemental. And we're lucky enough in our facility to have tomography, and we actually tomosynthesis. We do it on all of our patients. At this point, we don't. In New York State, we get paid for it, so there's not an additional charge. But we do it on all patients, regardless of their density. And we found cancers in patients, who are even fatty, that we think the architectural distortion, was more conspicuous on tomo than it would have been otherwise. And so I think that they're additive, and we want to give the patients every opportunity they have to find the cancer. This just indicates the different states that have the breast density notification. I think there's federal legislation out there. At some point, I expect this whole thing will turn pink. And then there's the states with like the star here, like in New York, for example, that in 2017, New York mandated that they pay for supplemental imaging for patients with dense breasts as well, that the insurance companies pay for that with no copay for the patients. And so this is just talks a little bit about payment. I'm going to skip that slide. And this is kind of, you can see the machine here. I'll skip through this. I'll tell you, we were an earlier adopter too, and you know, in just talking about our experience, my experience, you know, sort of the good, the bad, the ugly. When we first got it, we had callback rates of like 50%. We were just not really sure what we were looking at. There was a lot of dense areas that were shadowing, and you know, we were uncomfortable with. But the technology has improved a lot, and we've gotten, you know, they've improved it with much better equipment, and now our callback rates are under 10%, probably actually only about 5%. But one of the reasons that is that when we scan the patients during real time, the tech is actually looking at the scan. We use only ultrasound techs, experienced ultrasound techs to do this. We don't have, you know, some people want to have mammographers or, you know, medical office assistants or something, push a button. We don't believe in that. We have the actual ultrasound tech scan, watch while it's going, make sure it's a good quality scan, and then if they see anything, to flip the patient over right then and there and to do a handheld directed to that area. And this just sort of talks about how it's, you know, this, the long probe, it does a radial scan all the way around 360. It takes, how many images does it take? 900 images. It's a lot of images. And then it reconstructs them, so you can just see it kind of scans all the way around. When you come up here and look at this later, it's kind of like a martini glass. It's kind of a very shallow martini glass, about a 10-degree cone shape, so the breast kind of falls into there. The nipple doesn't always fall in the center, so you have to find the nipple so you can figure out where you are when you're scanning. This just kind of shows, and we can show this again when we have the model patient come up. Just kind of skip through this. We'll look at that in real time. And then this is how it looks. And again, you'll get to see this where it scans around and the tech is watching it as it goes across to make sure that there's a good quality scan. That, you know, some of the artifacts are related to poor contact. There's oftentimes some shadowing behind the nipple. I think they improved that a lot with the cone-shaped, because the original one was flat, and then they made the cone-shaped. And then you can very easily convert the table into to scan, you know, like a regular table. You just flip the patient over and direct an ultrasound to that area. And this is just kind of an example. I don't have the workstation hooked up today to show you cases on the workstation. I do have some cases I will show you that are confirmed cancers, though. But you basically can take that data set in a 3D volume and reconstruct it and look at the images in any different plane. It takes, at this point, there's 3 of us that do the lion's share of these. And at this point, it takes about a minute per breast. You know, one of the things that's different about doing screening breast ultrasound versus handheld ultrasound is really a diagnostic test rather than a screening test, because you're acquiring the images and looking at them right then and there. You know, I liken it to the way that if you do ultrasound is the only modality where the techs are actually looking at the study while they're doing it. When they do a CT scan, they acquire the images, they make sure they got all the anatomy in the field of view, and then they present it to you for interpretation. Yes, they will come to you, a good tech will come to you and say, hey, I see something on this one, you know, is there a bleed, or is there a mass, or do you want delayed images for an adrenal nodule or something like that? But for the most part, they're just acquiring the images and giving them to you to interpret. Ultrasound, typically, in most institutions, is done where the tech is, the interface is actually scanning and looking at things, getting good pictures, and making a lot of decisions right then and there, and then presenting it to you. You know, with a breast ultrasound, everybody has a different way of doing it. Some people will only do clock face, you know, 12, 3, 6, and 9. Some people will do, you know, 12, 1, 2, 3, all the way around, radial and anti-radial. It depends on what your comfort level is with your technologist. But if they come to you and said, I did a screening breast ultrasound and I didn't see anything, you're going to look at the images that they provided you, and then some people are going to go in and scan those patients themselves, and some aren't. You know, we were in our practice, we wouldn't go in and scan that patient again unless it was a diagnostic and there was a reason we were looking for something. But if you think about it, the way that they did that, it's more of a diagnostic test than a screening test. The screening test, where they just like a screening mammogram, they acquire the images and they present them to you. They should bring it to your attention if there's something abnormal, if they see it, but that's not their responsibility. And so one of the drawbacks to this is if that, for example, if it's negative or even if it's positive, they come in and show you the ultrasound and say, okay, there's an ugly cancer, ugly mass. You're going to address that, but you're going to hone in on the images that they provided you. Whereas now you have to actually, you're almost in a sense doing the scan yourself because you're looking at all 900 images. And the way that I like to look at them, I do them two ways. One is, this is the workstation here, and you can see that they've reconstructed the images so they're in an axial plane here, and then this is showing you the coronal plane. And I don't know if it shows on here, if I can scroll through it, but what I do, and here's just showing the different planes, but what you can do is scroll through. You scroll through, you take this line here and you just grab it and you drag it around in 360 degrees, and that shows these images will fly through and show you those in cross-section, in the axial plane, basically the way that they were acquired, or in the radial plane, I should say. I also like to look at what I call the source images. So I fly through them, I power cine through them on the PACS, but I look at all 900 images. And I'll show you a couple examples of how I do that. So here's a case of a 46-year-old woman who had a positive family history of breast cancer. Most of the cases I'm showing you are actually category Cs. When we initially started this, we did only category D patients, which is about 10% of the population. But then the question was asked, well, why, we have to send out a letter to all these C patients as well. Why aren't we scanning those patients? And so we ended up opening it up to do the C patients, and it was kind of surprising to us that we found a number of cancers in those patients as well. So this was a patient who was category C, and this is what I'm talking about. These are just the source images. This is basically, I'm scrolling back and forth on the PACS, and then they took this with my iPhone, but this is, you see this hypoechoic shadowing mass here, and so, and this was about 11 to 12 o'clock. We did a handheld ultrasound, found it, biopsied it, and it turned out to be invasive cancer. This is the same patient where we ended up doing a breast MRI on just to look for multifocal, multicentric, or contralateral disease. And this just shows that same enhancing mass at the 12 o'clock position with a biopsy marker associated with it. Here's another patient, 69 years old. Also a positive family history of breast cancer. Again, she was categorized as category C. She had a negative biopsy in the past with a surgical scar marked. This Sofia, for whatever reason, whether scheduling, we can usually do them on the same day if we have it opening in the schedule, and we probably do about 2/3 of the patients who get the Sofia on the same day, right after they have the mammogram, if they're a category C or D. Occasionally, because of if our schedule is full, or if the patient wasn't planning to have the ultrasound today and they have childcare needs or other appointments, they'll schedule it to come back later. Once in a while, they want to make sure that it's okay with their insurance company. So this was a patient who was done 4 months later, and we saw this. Did this play? I don't know if that played. Did that scroll while I was talking? We saw this hypoechoic area with calcifications in it. So we brought her back, did an ultrasound, again saw the mass with the calcifications in it, and then actually went back and did another mammogram and saw these calcifications here, biopsied this, and again this was invasive cancer with DCIS. Here's another cancer, another patient who was extremely dense, 49 years old, also with a positive family history, previous benign biopsy. And I don't have the source images for this one, but this was this hypoechoic mass here. This shows it in the sagittal plane, and that would turn out to be an invasive cancer as well. So And you'll get to see a patient get scanned live. The scan itself takes about 30 seconds now. It used to be a lot longer than that, but they've really, honed it down. It used to be, when we first got it, there was it was one half-size transducer, and they had to scan all the way around and then scan all the way back. Now they have the single large transducer that can go all the way around in 360 degrees in about 30 seconds. Again, it takes about a minute to review it if it's normal per breast. It takes a little bit longer if there's an abnormality that you see that you want to localize and then have the patient come back for a directed handheld ultrasound. The other reason to call the patients back are for technical reasons. If there's poor contact, we do see areas of shadowing that we, question, are they related to, Cooper's ligaments and Sharpie's fibers, or is it an actual mass? We call those patients back. A number of times, some techs more than others, the techs will flip the patient and say, I saw some shadowing here, I flipped a patient, didn't see anything when I did the handheld, and they provide you representative images, and so you don't have to call that patient back. I also when I read the ultrasounds, I read the mammograms contemporaneously. I find it, if I think I see something on the ultrasound, and I look at that area on the mammogram and it looks like fatty tissue, that I'll oftentimes just dismiss it. Whereas if it's a dense area, then I'm more because not all the patients are dense uniformly. It might be just one area that's dense. So I'll bring that patient back to look with handheld. And again, our callback rates are about 5%. We're finding a couple of cancers per 1,000 patients that we're screening. It's lower than the Akron 666, but again, that's those are patients who are at increased risk for cancer, patients that were done with, handheld ultrasound. This is not, I think it's not a fair comparison. In a perfect world, every woman who has dense breast would probably have a screening ultrasound, by Dr. Stavros, take 45 minutes or something and really have like the most thorough possible exam. That's not feasible out there in the general population. And so when, the reasons that we moved to this technology is because it's fast, reproducible, it's comfortable for the patients. We are finding cancers. Our false positive rates are, or I should say our positive predictive values are probably about 10 to 20%. So it's in line with what the other studies have shown. I mean, there's definitely, you're going to find more things that aren't cancer that you're going to biopsy than things that are cancer, but that's true with mammography as well. But it's, with mammo, it's accepted, anywhere 20 to 40%. With ultrasound, there's more false positives. We don't really know what our false negatives are at this point. I can tell you that I don't know of any cases where the patients had a Sofia, came back with a cancer anytime in the, like an interval cancer, 6 months later, that we saw on the ultrasound or on a mammo later on that we didn't pick up initially. I also think that we got a bump in our cancer detection rates with tomosynthesis, and so using it contemporaneously with the ultrasound, I think that we find, we're definitely finding more cancers than we used to with standalone, non-tomo mammo. And one of the questions I get asked is, what about patients who, for breast MRI? We have a pretty robust breast MRI practice. We do it on any patient with a 20% lifetime risk based on any of the models. The insurance companies will pay for that. Do those patients need a screening breast ultrasound? I think the Akron 666 said that they didn't, and I tend to agree that they probably don't. Our patients oftentimes want it anyways. And so, one of the things is it depends on your patient population. If you have, our patients kind of demand, there's a lot of walking well, but they want every test possible. We do have a higher incidence of breast cancer in Saratoga County than in some of the other areas in New York State. There's a lot of theories on why that is, but I don't know if they've really isolated it. Maybe it's in the water, but it definitely is true. But we do, our patients are very educated, and they really want every possible test. And again, it's paid for. I still think it's, to some extent, an evolving technology. It's way better than it was, even just 3 years ago. with much better transducers now and much better system, with the 900 images. It's a lot of images to go through, but if when you're power scrolling through it, you can see when it goes on here that you can really see quite a bit. I mean, it would be impossible to get 900 radial images perfectly by hand. I don't even take you an hour to do that. If you're trying to do that by hand. Some of the other limitations of it, if it's and a patient's got extremely large breasts, sometimes the lateral aspect of the breast won't fit on, and what we'll often do is do a second scan where we reposition them off center and scan the lateral aspect of the breast. People ask about how it is with implants. It actually does pretty well with implants, not so much for the integrity of the implant, not any better or worse than handheld ultrasound, but what's nice is the implant almost acts as a behind the breast standoff pad in a way, so it actually compresses the breast tissue, and so you could often you really get a good look at the breast tissue that overlies the implant. What else? It's very comfortable for the patients. They're on the table less time than they are when they're having a handheld ultrasound. And you can talk to our model and see what her experience is with it. What else can I tell you about here? And I want to make this interactive. If anybody's had any questions, I know you've been sitting in lectures all the past day and a half. I'm happy to answer any questions that anybody has, and I'd like to have our model get up here and get scanned, and you can see how this runs. And while they're doing that, does anybody have any questions? Yes?
Do you flip them every time the scan the axilla then after you're done?
We do not. In our practice, we don't view that as part of a screening breast ultrasound. Some practices do. That would certainly be a choice that you could make if you wanted to do that, if you were to invest in this system. We're at the point where we're doing probably 10 a day now, so they're kind of like we do a lot of them. And that's the other thing is, like, if you're a low volume practice where you're only going to have a couple of screening breast ultrasounds a day, I don't know if you're going to want to invest in an automated system, but if you're going to have the kind of volume that we have, I think that it would be impossible. The techs would have a mutiny if they had to keep doing this many ultrasounds by handheld. I had something else I was thinking about. Do you have any other questions right now?
Any CAD software works at all?
I don't know about that. I know that there's some talk about that by the guy who developed this, but he's got a lot of big ideas. One thing I will say, as an earlier adopter of the technology, is, and I was talking about this with some people earlier, I believe, I'm not going to push and say what you should have done. I just think you should have something done. I think we all know that there are these dense breast patients where mammals are just not that sensitive in detecting the cancers. There's too many cancers that are being missed, and something needs to be done for those patients. Whether it's handheld ultrasound, whether it's automated screening breast ultrasound, whether it's MRI, something needs to be done for those patients. And I would prefer to see those patients get addressed one way or the other. If it's going to be, if you have enough volume, I do think that this system works. And like I said, as an earlier adopter, we've seen progress made. I expect that there will be more progress made. The logic I use is sort of the flat screen TVs. If people didn't buy flat screen TVs early on, we wouldn't have the technology we have. We wouldn't even have these if people weren't buying their phones and stuff like that. So I think, and I'm not saying that as a sales pitch, but I think that the fact that this technology has evolved. I mean, I only see it potentially getting better. I think, like I said, in a perfect world, they would probably have every test. I'm also a big believer in breast MRI. I'm a big believer in breast imaging. But if you have enough volume, you have enough patients that need to be scanned, I think this is a very viable option. You want to go ahead and start here? Yeah.
Can I ask,
yes.
What sort of volume are you currently doing? When you talk about volume, how many patients do you?
We're probably on pace to do 3,000 this year. maybe more. I think we were in like 2,000 after 3 quarters this year, 2,000 something, maybe 2,200.
Right, and how long or how many reads did you require before you got pretty comfortable? Presumably your recall rate was higher, you know, say your first 100 or first 1,000.
I mean, there's a certain amount of time. I'd say probably the first, 50 scans or so before I really started to get used to it. Because, I mean, you've been doing this all along. You've been doing ultrasound. What's interesting is, when you start doing this, you realize what the techs are doing. I mean, everybody has varied experience. I've talked to radiologists that do all their own breast ultrasounds. That's how, when I was in residency, that's how we did it. We went and scanned the patients ourselves. But, out in private practice, most of the time I have the ultrasound techs do the scan, and if it's a diagnostic scan and I'm chasing something and they don't see it, then I go, we got to go back and look together. But if I see, if they're one of the, and we have a lot of good techs, they present to me a negative study, I scroll through the images, but frankly, it's probably a little bit more perfunctory, right? Just being honest, because they come to you and said, everything looks good, I mean, just like you scroll through a right upper quadrant ultrasound, everything's on the worksheet is decked out. You might go back and look at the CT and then say, hey, wait a second, there was a hemangioma in the liver on the CT, why didn't you see that? And address that. But otherwise you would, kind of go with what they had. So, but it's interesting because now you're looking at 900 images on every breast. Again, they're sequential, and I cine through them, and like I said, I kind of power cine through them, so you see them, quickly, and then I also look at the 3D at the same time, with the multiplanar reformations, and that's particularly necessary if I see something on the original source images.